Hi, my name is Brad McGregor, and I'm a GU medical oncologist at Dana-Farber Cancer Institute, where I treat patients with kidney cancer. And I'm really excited to talk about the developments we're seeing in the treatment of kidney cancer, specifically that for papillary renal cell carcinoma. So if you think about kidney cancer, the most common type is renal cell carcinoma. Within it, the most common type is clear cell. And for a long time, we said, oh, there's clear cell or non-clear cell. And now we're realizing but that's really doing it disjustice. There's clear cell, and there's a lot of divergent histologies. Among them, the most common type being papillary RCC. And, as we think about papillary RCC, this is something that the pathologist will diagnose. They look at the cells on the microscope and they'll say what the cells look like. And what we're realizing now is that just as it's not really fair to call it non-clear cell RCC, papillary RCC actually includes a variety of different tumors with different molecular drivers and different characteristics. We used to say, oh, it's type 1 or type 2. That's really gone away. As you sort of say, there's sort of looking at each papillary tumor as its own unique entity. And as we do that, we've really made a lot of advances in the treatment of papillary RCC. Obviously, for localized disease, as with traditional kidney cancer, the goal is to take out the kidney. There are trials ongoing, specifically in papillary RCC, evaluating can we do immunotherapy with a vaccine or immunotherapy alone or immunotherapy with a pill to see if we can improve outcomes overall. And as we start thinking, when papillary RCC spreads outside the kidney, what is the best treatment? For the longest time, we would sort of extrapolate, say, well, we have this data in normal kidney cancer, let's try it in papillary RCC. But then more recently, we've had lots of trials that really look specifically at these divergent histologies, including papillary renal cell carcinoma, starting with the PapMet, which really established cabozantinib as a standard of care. And even from that trial at the very beginning, we could start to see that all papillaries are not the same. And they look at that trial looked at patients who had papillary RCC, and they actually tried to give sort of very specific MET inhibitors. And those trials actually had to stop for futility, and only cabozantinib continued. And that's primarily because, yeah, papillary RCC is a diverse group of tumors, and a majority may not be MET driven and won't get that benefit from that pure MET inhibitor. More recently, we've had several single-arm phase 2 trials looking at the role of IO immunotherapy with a TKI, with cabozantinib and nivolumab, with that and pembrolizumab, showing encouraging response rates over 50%, as well as the Sunny forecast, look at the role of nivolumab and ipilimumab in patients with papillary and patients with divergent histologies, including papillary, showing encouraging responses. So really bringing the era of doublets from clear cell into those patients with papillary, which is incredibly exciting. And at the same time, we're looking forward to ongoing randomized trials, really trying to solidify that doublet strategy is appropriate. With the ongoing STELLA trial, looking at zanzalintinib with nivolumab versus sunitinib, and the PapMet-2, really saying does the addition of atezolizumab to cabozantinib improve outcomes overall, and really try to solidify the exciting data we've seen with the doublet single-arm trials. And as we look towards the future, I think we're going to be looking not just at papillary, but sort of like looking at genomics. And I think we've shown we can do that. We had the Savoir study, which looked at savolitinib and MET-driven papillary RCC with encouraged response rates. And that's the basis for the accrued Samantha trial, which was looking at savolitinib, various potent MET inhibitor, with durvalumab versus sunitinib or durvalumab in those patients with MET-driven RCC. So really taking that next step and saying we're going to look beyond what we see on the microscope to the genomics and really try to improve outcomes. And I think that is the future of how we're going to improve outcomes for patients with these divergent histologies, is collaborating with industry, with the lab, across institutes to ensure that every patient who has these divergent histologies is able to get access to clinical trials where we can learn from every patient today so we can improve patient care tomorrow.